it's mostly just about cirrhosis. So it starts on page 986. This is from your Threats to Nutrition module. So it's a different module than your renal. So I'm just going to talk briefly about the liver, the anatomy. This will be review for you. So the liver functions as a filter, right? It secretes. It is very vascular, and it stores stuff as well. It produces procoagulants, which are vital for hemostasis and blood coagulation. Stores iron. So it keeps a balance. So the liver's made up of what kind of cells? Who can tell me what kind of cells? Hepatocytes, beta cells, yeah. And hepatocytes also make bile and secrete it. There are capillaries within the liver. And you may hear the term sinusoids. You may hear me talk about sinusoids. Those are your capillaries within the liver. So you have a hepatic artery. And if you can see. Right here. So it brings your blood in, right, from the heart. And then you have your portal vein down here that brings in nutrient-rich blood. From where? Who can tell me where? The mesenteric, right? Like the intestines. And so you got nutrient-rich blood that comes into the liver. And then if you see that green arrow down, you have bile that drains down. So you have both oxygenated blood and deoxygenated blood that enter the liver. In your common, in your capillary bed called the sinusoids, right? So this is just another picture. The reason why I like both of these is because the one picture shows you the whole, abdominal cavity and everything that's in it, and how the liver, we're going to talk about how the liver affects all of it. So that's why I like that picture. And then the other one, I just like all the vessels, so I can show you about the vessels, so I can give you the review. But this one shows you a little bit more about the flow and how vascular the liver is, if you look at the one on your left. So that's why I put that one in there, and it also shows the gallbladder, and we're going to talk about how vital the gallbladder is as well to everything. The liver only weighs about 3 pounds, which is kind of heavy, I get, kind of big. It is a large organ, has 2 lobes. This is my attempt of drawing it. I never can draw the liver. When I tell my daughter, this is how it always looks, and she laughs at me. And she's an artist. She's an artist though, so she could do it good. I should have took it home and let her draw it. But anyway, it's got 2 lobes, and who can tell me what this is? Inferior vena cava. It goes down and splits, right? And then who can tell me what this organ is? The spleen, right? And then right beside the spleen that's long and slender. Pancreas, and then the stomach is right here. Yeah.
Somewhere in there.
Yeah. So then this other vessel that's not really colored in, that's your portal vein that goes down. And I just drew some squiggly marks for your intestines. Anyway, that was my attempt at drawing. I was going to try something different, but I couldn't get my computer to connect so I could walk around with my dossier. But I couldn't get my computer to connect, but I'll try that again. I may be doing my lectures different, walking them, walking out there with y'all. I might sit on the back row with y'all next time. Not y'all, the next group, because this is my last time lecturing to you all. Yay! No. So yeah, this is your last lecture other than HIV. So next Tuesday, we'll do HIV, and you'll be done. Because you're going to have your test Monday, and Tuesday's your HIV lecture. So it's really like right here at the end, right?
Hold on, I wasn't ready to cry yet.
So the other picture, the reason why I put it up is because it shows the portal vein, and it shows how it has all these branches, right? So the blood, the nutrient-rich blood comes up from your intestines, but it also your inferior mesenteric vein is also involved there. Your superior mesenteric vein, it all attaches there to your portal vein. See how it all kind of connects? And that's why I like this picture, because it kind of gives you a bigger idea of how it is all connected. All right. So the main job of the liver involves metabolism, right? Carbs, lipids, proteins. And so you get to maintain a normal glucose level because the liver breaks down glucose, right? Y'all remember glucogenesis? Okay. So it breaks down glycogen to glucose and releases it into the bloodstream. So that's a big job, right, for the liver. And I already told you it stores iron, it keeps a balance, it produces procoagulants, which are vital. And it also, the hepatic duct, the common bile duct and the hepatic duct here, delivers bile. What is bile? Who can tell me what bile is?
Product used to break down fats to digest.
Right. It helps you digest. It breaks down fats. So that's vital, right? Very, very, very important. It's stored in the gallbladder. So hepatic duct delivers bile to the common bile duct. From the liver, it's stored in the gallbladder. The common bile duct passes into the duodenum to deliver the bile down to your food, starts breaking down your food, helping you with digestion. Why is that important? Because we're going to talk about a tiny bit about fatty liver, right? And what happens when it's not breaking all that down. So also the liver conjugates bilirubin. And then it removes, so like as a filter, it kind of removes hormones that are not needed. So it does a lot of stuff, doesn't it? So when there's a problem with your hepatocytes and with the flow, you're going to get a problem called cirrhosis. What exactly is it? What is cirrhosis? Well, there it is for you. It's chronic destruction of the liver cells or your hepatocytes with fibrosis. What is fibrosis? Fibrin buildup, right? Think scar tissue, fibrin. So it results in the obstruction of bile and the vascular flow. Remember I said the liver's very vascular? So if it's not flowing well, if the blood and the nutrients can't get there, we got a problem. What are some causes? What makes this happen? Well, alcoholism, for sure. Chronic hepatitis C. Viral infections. Autoimmune disease. Malnutrition, so extreme diets can cause this. Didn't know that, did you? Extreme diets. Sometimes environmental factors can cause cirrhosis, genetic predisposition. So all of these things can cause cirrhosis. So when you're taking care of that patient in the hospital with cirrhosis, don't just automatically assume that they're an alcoholic. Because they're not always. So again, early cirrhosis has very, very vague symptoms. You're going to see some vague GI symptoms. You're going to see some, well, you won't see it. I mean, you could feel it sometimes, but hepatomegaly. We used to have you all, palpate the liver, and if you go to nurse practitioner school, you will definitely learn how to do that. But you can actually palpate an enlarged liver. You can also see one on imaging. So early signs and symptoms are very vague. So you got an obstruction of bile and vascular flow, which is carried by the portal vein, right? You also are going to have some spleen problems because your blood, when it starts backing up into the spleen. And then you're going to get splenomegaly, an enlarged spleen. So then, because you've got such a big spleen, you're going to have more red blood cells over there. The spleen's going to take in more red blood cells. So you're going to have some problems with your blood labs, right? You're going to see some. Then you're going to add in the problem if there's damage to the hepatocytes in the liver. Then you're going to have some coagulation problems. So you're going to have all kinds of problems with your hematologic panels.
So they'll bleed more.
They'll bleed more, they'll bruise more, they'll have a longer prothrombin time. We're going to go over all that, but yes, lots of problems there. So again, it's vague, and in the beginning, you might see some elevation. Who can tell me the labs that they might draw? AST and ALT. So yeah, which covers your liver function test will cover that. Coagulopathies. Ammonia levels, because ammonia synthesized in the liver. Bilirubin. Good. We're going to talk more about those, but I just wanted to see. So what else might you see? I just added that little anorexia. You're taking care of people. They're alcoholics. They got cirrhosis. They're malnutrition. They look emaciated. So anorexia is a sign and symptom of it. Anorexia, back to your extreme diets, can cause cirrhosis as well. But you're going to see anorexia. And they're going to be kind of tired, so fatigue, which is very, very vague, right? But you might see that. So make sure you write down fatigue, anorexia, vague GI symptoms, early signs and symptoms, nausea, course. A lot of times when people are nauseous, they don't always eat, right? Does everybody know what dyspepsia means? Heartburn, just irritation there, just stomach irritation, indigestion, heartburn, dyspepsia. So now we're going to talk about complications. So what exactly is going on here? Well, what is portal hypertension? Because portal hypertension is a complication of cirrhosis, right? Portal hypertension is the derangement of liver cells which causes pressure in the portal vein. That's pretty self-explanatory, right? Portal hypertension is just derangement of those liver cells. As you can see how it looks kind of knotty? Those are fibrosis building up, right? Those vessels, those veins on your right here, that's not normal, is it? Nope, those are your varices. Because of the pressure, you're going to get almost like varicosities, right? Y'all seen varicosities? Because of the pressure here, so you're going to get the fibrotic liver. Chronic damage to your hepatocytes causes all this. So I want you to think about it. You've got a chronic damage to these hepatocytes. You've got this fibrin building up. So what do you think is going to happen to the vasculature there? It's going to be compromised, right? Clogged up, compromised. You're going to get collaterals. Just like you get in the heart, there'll be collaterals there. Well, because of that extra pressure, those little collaterals are going to burst, right? And what do you call those? Varices. Well, you also got a compression of your bile ducts. Not only do you have the compression of your vessels, but you're going to have a compression of your bile ducts. So then what's going to happen? Yep. And decreased bile flow, which leads to decreased ability to conjugate bilirubin. And you're going to see... Exactly. Right. What kind? Fatty stools. Sometimes they can be different colored, lighter. So you're going to have decreased bile flow, decreased ability for the liver to conjugate bilirubin, and then that's going to lead to jaundice, yellow eyes, yellow skin.
Is jaundice a late sign?
Yes. There was a good question up here. Is jaundice a late sign? Pretty much, yes. Again, early signs and symptoms, dyspepsia, fatigue, anorexia, some weight loss. But later signs and symptoms, this is a full-blown picture here of portal hypertension. Varices, they're not always in the beginning. They're a little bit later because you want to think about all that pressure, that lack of that backward flow of blood, and then the pressure. You get these collaterals and you get the varices. Backup of blood causes esophageal varices. Not only in your esophagus, but also even in your duodenum. They can have a GI bleed. So I just drew a line to show you. I already showed you, but those are your varices. They can go all the way up into your esophagus. So somebody could have a bleed in their throat. So there's not a picture here of an abdomen, but we are going to talk more about ascites. But you also get ascites because of the backward flow. You're not getting enough flow You're getting that pressure from the portal hypertension. You're going to also get ascites. I'm going to show.
I forgot. Does the spleen make the platelets or something?
The spleen. No, the liver. The liver helps with the platelets, but the spleen, all the blood the spleen does filter the blood and produce red blood cells. Helps with all that production. So it is vital. You've seen people live without a spleen though, but it's very vascular. So your portal hypertension impedes the blood flow of the spleen. It disrupts the coagulation panels and decreases platelets. Become sticky, and they kind of stuck in there. Does everybody have that? All right, so later clinical manifestations. I thought this was a great picture. Poor little guy. So you see the jaundice. You see these spider angiomas from your coagulation panels. Your anemia. So your labs, you want to think increased PTINR or prolonged prothrombin time, right? Increased AST, increased ALT, decreased albumin, decreased platelets. So those are some things you might see. Decreased protein, right? What are normal protein levels? Total protein. Does anybody know total protein? 6 to 8, 5 to 8, different, depends on the book you're looking at. Now we've already talked about, when we were talking about kidney, we talked about ammonia. So who can tell me what the liver does for ammonia?
Just filters it out, right?
Filters it out, breaks down the so if there's damage to the hepatocytes and damage to the liver and it's not filtering properly, it can by itself can cause increased ammonia levels. So you might see changes in mental responsiveness. Right here, increased ammonia. That's what's going to happen. We already talked about the esophageal varices. We're going to talk more about ascites, but we talked a little bit about ascites, collateral veins visible on the abdominal wall. The video talked about that caput medusa. Anemia, thrombocytopenia, and coagulation disorders. Hemorrhoids, we already talked about that. That's important to know. You're going to tell your patient not to strain. And y'all remember me talking about how the liver synthesizes and secretes hormones? Well, you might see as it fails to remove hormones. So you might have increased estrogen in men, which can cause gynecomastia. And then in women, hirsutism, like facial hair, like men. So you might see increased testosterone in women. And then, of course, peripheral neuropathy and edema. What do y'all think the reason for edema is? the backup in your systemic system as well, but also low albumin, because what does the liver do for proteins? Makes the proteins, right? Well, if it's not functioning, you're going to have a low albumin, which creates a low oncotic pressure. Oncotic pressure does what? Pulls. Hydrostatic pressure does what? Pushes, right? Do we have? Yeah. All right, so let's talk a little about jaundice. What is it? Well, it's yellow discoloration of body tissues because the liver can't conjugate bilirubin. So what are we going to see? We're going to see yellow discoloration of your eye, the whites in your eyes, the skin or the sclera, even the palate. So if you have someone with darker pigmentation skin, then sometimes you can look in the palate of their mouth and see yellow, or their eyes. They may have pale stools. They may be itchy, so you're going to have to think about, do they need lotions, oatmeal baths, baking soda. They need short nails so they won't make sores on themselves. You'll see dark urine and pruritus. You may hear it referred to, the yellow eye, as icterus. That was a word started years and years ago. I think it's a yellow bird, so people were calling people's eyes icterus because of a yellow bird. So what do we do for these people? Well, like I said, you want to do measures to relieve the itching. Oatmeal baths, they may need Benadryl, hydroxyzine, but that's not your first choice. It's cutting the nails and giving them oatmeal baths or the alpha carry baths. But you can give them hydroxyzine or Vistaril. Lotions for itching, short nails. You want to monitor their stools and their urine. So we talked a little bit already about esophageal varices, but what is it? It's enlarged veins as a result of portal hypertension. What do you see with it? Mild, they can be mild or moderate. So you can have a small bleed or you can have a major bleed, right? And the reason why I point that out is because there's different treatments for both. You got to think about, is it a mild bleed or are they bleeding out? Are we looking at a GI bleed, or are we looking at hypovolemia? That kind of thing. You got to think through that. So, as far as the treatment goes, again, is it a mild bleed or is it a moderate bleed? Well, endoscopy with ligation, which just means, does anybody know what ligation means? Anybody had tubal ligation? Tie it off. And sometimes burn it off. So they use these little bands and they ligate them, the vessels that are bleeding. So they send them to endoscopy and do that. Now, or sclerosis, basically they burn them or laser them. Drug therapy. If they're dying, so they're bleeding out on your table in the ER, then you might have to start a vasopressin drip with nitro. You're not going to say, oh, they're bleeding out, let's send them to radiology or let's see if endoscopy's open, and we might have to get a team in there, so 30 minutes. You know, you're not going to send them for that if they're bleeding out, right? But you are going to start some vasopressin and nitro if they're dying. Octreotide is another medicine, or sandostatin. And it's just a somastatic agent that's specific to reducing portal venous pressure. And it kind of decreases the blood levels of a variety of hormones, so therefore it helps with bleeding varices. So octreotide or sandostatin. And then after, that's a P with a line over it, after the second or third episode, they may do what's called a TIPS procedure, and that's just a let me see what it says. Anyway, it's a transjugular intrahepatic shunt, basically a shunt. And it just redirects the blood flow from the portal vein to the hepatic vein. And that's not your initial treatment. That's after the second or third bleed that they're going to do that. And the reason for that, and we're going to talk about it, is it increases the risk of hepatic encephalopathy. And we're going to talk about hepatic encephalopathy because that's important to know too. Another treatment for bleed is a Synstakin Blakemore tube. A balloon tamponade is the generic name. Synstakin Blakemore is a name brand of a tube. Balloon tamponade is just a general term for it. I have a whole slide on that, so we're going to talk more about it. Okay, you want to think, if they're bleeding out, you want fluid replacement. They might need blood, but they definitely need some volume. A stat CBC, CMP, PTINR, APTT. So you're going to get some stat blood work. You want to see, you got to see how bad off they are. How sick are they? You can also tell that from assessment. Are they alert? Are they oriented? Their heart rate good and strong, or is it weak and thready? What's weak and thready? Hypovolemia. You may have to give them transfusions. Blood transfusions. Monitor your H&H. They might need fresh frozen plasma or vitamin K. You're going to teach them to avoid NSAIDs and aspirin. PPIs. What are PPIs? Protein pump inhibitors. What do they do? Acid production, right? What does acid do? It hurts. It breaks down the mucosa and causes a bleed. So you can further cause problems. So you're going to treat them with a PPI. And then long-term management, they may, if they have known varices, they may be on some non-selective beta blockers. This is more long-term, not your initial treatment.
The non-selective beta blockers is to help. Usually they have cardiovascular problems. Is that what that's for?
Right, and it also
Helps with the vascular
right,
tension.
right. This is for somebody like reoccurred bleeders. So you're blocking that beta response because if you are fight or flight, your heart rate's going to go faster, so you're going to bleed more. So long-term management, you might see someone on non-selective beta blockers. They might need repeated bands. And then what did I say they might get if they have reoccurring bleeds, like after the second and third time? The TIPS procedure or the shunt, right? I'm going to add that. Okay. So the tube, this is your Sing, Steak, and Blakemore tube or your balloon tamponade. See how it goes all the way down the esophagus into the stomach? What do you think a risk for this is?
Bleeding out.
It's a treatment for varices, and you can aspirate on this tube, right? You can choke to death. Asphyxiation, choke to death. Does everybody know what the word asphyxiation means? Okay. With this, also, you're at risk for esophageal necrosis, because if you want to think something that's pressure, like a pressure sore in your esophagus, because it's just pressing. So you're at risk for esophageal necrosis. So with this tube, they have to have, you have to deflate it, and they have to have a break from it. You also might need to suction them. Encourage for them to spit up any extra phlegm. But you do have to deflate the balloon every 12 hours to give them a break so they won't go necrotic. So you're monitoring for signs and symptoms of rupture, erosion of the esophagus, regurgitation. You're also monitoring for aspiration, so you're listening to their lungs. And then also so these patients, this patient, they're going to be in ICU, right? You're only going to have 1 or 2 patients, possibly 3, but you're monitoring this patient very close. So the most of the time, anyone with balloon tamponade is going to be in ICU. You need to keep scissors at the bedside. Why would that be a thing?
Cut that thing, take it out.
Right, if they're choking, you got to cut it and pull it out. And you have to monitor them closely. And the reason, part of it is you got something stuck in your throat, right? So they're not able to swallow saliva. So they could aspirate on saliva, on fluid. So they're going to need, like I said, frequent suction. Airway, airway, airway. With this. Airway, airway, airway with bleeding, right, too. If they're bleeding varices, what do you think your priority is?
Aspiration.
It's not to go get them 2 units of blood. It's to keep their airway clear. If they're bleeding, varices are bleeding, your airway is your priority. All right, this is just a quick little TIPS procedure. it's a visual for you. It shows you that they do an anastomosis. The blood is completely, purposely diverted from the liver. Transjugular, intrahepatic, portosystemic shunt. And there's different ones your book talks about as well. I'm not going to really get into those. Those are good to know if you want to look at it. You think you might be working with some liver patients, definitely review it. But I'm not going to go into it. This is the main thing you need to know is that they may do a TIPS procedure. It's usually after the second major bleed. They do it in IR, which is interventional radiology, and it basically redirects the portal blood flow. You have an increased risk of encephalopathy because even if the liver is not completely working, it still might, there's still some ability of it to break down some of that ammonia. And if it's not going in there at all, then you have an increased risk of increased ammonia levels, for sure. If it's not even getting the chance to try to break it down. Everybody get that? I want to get into gross ascites. That's a complication of liver. What is it? Portal hypertension results in protein shift that leak into the peritoneal cavity. So your protein shift from the blood vessels via the larger pore of the sinusoids or your capillaries, and it leaks into the lymph space, and you got all this extra protein, and you don't have enough pressure to move all that extra stuff. You don't have enough hydrostatic pressure. It's kind of a domino effect. There's a few things that happen here. Your book covers it really well. So you have an impairment of the liver synthesis of albumin. That results in hypoalbuminemia. Hypoalbuminemia results in decreased colloidal oncotic pressure. Oncotic pressure pulls, hydrostatic pressure pushes. So you have an impairment of the liver synthesis of albumin. Also, you have an increase in aldosterone due to the liver's inability to metabolize it. So therefore, what does aldosterone do? Hold sodium. Water follows sodium. So you have, because your aldosterone, the liver is not able to metabolize it, you're going to have increased reabsorption of sodium. Hence, all this swelling in your abdomen, all this fluid. There's also like I said, so you've got your protein shift, your hypoalbumin, your low albumin. Yeah, just low albumin. And then you've got this hyperaldosteronism. So you got a domino effect here. All these things causing this extra fluid, this huge abdomen. So, enlarged abdomen is your clinical manifestations. Increased girth. Does everybody know what that is? You measure the abdomen, so you're going to have a larger girth. If you've ever been pregnant, sometimes they measure your girth, your stomach. You may see the caput medusa, which are the varicosity-like veins on the abdomen, or enlarged veins. Hypokalemia. So what are we going to do for them? Well, they're going to be on a sodium restriction, 2 grams a day. They may need albumin, diuretics. Diuretics can cause what? Hypokalemia too, right? They may get a medicine called tolvaptan. Aldactone or spironolactone. What does that do? Aldactone blocks the action of aldosterone, right? And it is potassium sparing. So they might be on spironolactone or aldactone. So that would be why aldactone is used for ascites. If you've ever had a patient that had ascites, most likely they're on this. They're on spironolactone. So it's not just for elevated blood pressure, is it? But it helps with the blood pressure.
One of the patients I saw at hospice had a
So they're at risk for spontaneous bacterial peritonitis because of the decreased immune function and the extra fluid sitting there, because you already have some natural bacteria in your GI tract. So that would be treated with neomycin or rifaximin. And then, of course, aldactone for the ascites. So what do you think diuretic therapy, what do you think that is? Right. What do you think you're going to be telling them to do for their sodium intake? 2 grams a day.
don't put salt on stuff and don't buy frozen.
Right, look at their labels, right? Look, I saved you some writing. So with paracentesis, they need a consent. They got to pee or void before they do the procedure. Do most patients know what the word void means? No. Make sure that you give them terms they can understand. So, do we get them to sign the consent? No. But we have to make sure there's one there. Right? And sometimes we witness as RNs, not as students. That's what I'm going to tell you when we go to management. Don't witness any consents. So they need to have a consent. They need to void before they go to the procedure. So they'll call you and say, we're coming to get them. You need to make sure they empty their bladder. They're going to be put in a high Fowler's position or sit on the side of the bed. And just like with any kind of procedure, you got to think they've got a puncture in their abdomen. You need to assess for bleeding, monitor for infection, and monitor fluid and electrolytes because they're removing all this fluid. So what else could happen? Low, all of that could go low, but also hypovolemia, depending on how much they remove. So you're going to monitor for hypovolemia. All right, so I wanted to talk to y'all about hepatic encephalopathy. What is it? So your toxins or your ammonia is not detoxified by the liver, so then it can cross the blood-brain barrier. Ammonia can also be produced by bacterial action on the amino acids in the intestines. And normally it's converted to urea in the liver and excreted by the kidneys, but if your liver's not performing, it may or may not do this for you. So change in mentation, change in mental status, right? It's basically, what is this? It's another complication of liver failure that can lead to coma. So it's a complication of liver failure that can lead to coma. Hepatic encephalopathy. This is important to know. What is it? What do we look for? How do we treat it? So your clinical manifestations: change in level of consciousness, confusion, asterixis. That's when the hand flaps. Get them to hold their hands up, I think, and it flaps. Hyperreflexia. Mnemonic for you. So your portal systemic encephalopathy, hepatic encephalopathy. You increase blood ammonia, you're going to see changes in LOC, confusion, impaired thinking, neuromuscular disturbances, or the asterixis, hyperreflexia. Well, it's increased by increased protein, right? Because what is protein? Made up of amino acids. So increased problem, you're going to see an increased risk if they have infection, hypovolemia, hypokalemia, or a GI bleed. There's a chart, I believe it's 4311. No, is it? Yeah. Factors precipitating hepatic encephalopathy. Page 990. It's a good chart to know. Okay, so I just have a picture here of this asterixis. So this is just a picture on this slide. It's basically a result of hepatic encephalopathy, but I've got collaborative care here. How do we treat hepatic encephalopathy? What are we going to do about it? Well, we're going to decrease the ammonia by lactulose. This is an important med to know, lactulose. Lactulose decreases pH, decreases bacterial growth, and it traps ammonia in the gut. And if you've ever administered this and taken care of anybody on lactulose, you'll never forget it. They usually have diarrhea. So you want to decrease bacterial growth, like I said, for that extra fluid in the abdomen. You're going to give neomycin, rifaximin. And you want to try to prevent constipation. If they're on lactulose, you don't have to worry about that. But if they're constipated, what makes up our stool? A lot of bacteria, right? So that will further add to the problem if they're constipated. You want to treat the precipitating cause. Are they dehydrated? Treat the cause. Are they constipated? Treat it. What are these precipitating factors? Are they on opioids? Decrease in metabolism by the liver, causing higher drug levels and cerebral depression. So you want to treat the cause. So factors that increase NH3 or ammonia. Beware of problems that can worsen it, such as dehydration, GI bleed, infection. This is right from that chart in your book. Hypokalemia, cerebral depressants, TIPS procedure, because it's totally bypassing the liver, and constipation. So all of those things can worsen or precipitate hepatic encephalopathy. Lactulose is a great treatment for it, right? Rifaximin, neomycin. Okay. Did everybody get that? How could a paracentesis precipitate it or worsen it? Risk of infection, where you're hypovolemic, right? You're dehydrated. You're pulling all that fluid off. So it can worsen it. So you're going to monitor these patients closely. Now, you're going to monitor ammonia levels. And you're going to do neuroassessment. This liver biopsy is, sometimes they'll do a liver biopsy to see, what stage, what's going on with the liver, how progressed is the cirrhosis. Of course, they do a liver biopsy if they think you have cancer. But again, with liver biopsy, you want to make sure there's a consent, pre-procedure lab, CBC, PTINR, and post-procedure, and you want to start by this, you want to make sure they lie on their right side. Because it helps to clot, because the liver is very vascular, right? So if they lay on their right side, that creates a little bit of pressure, and the liver will clot, the area will clot better. So your liver biopsy helps with diagnoses. As far as labs, what are you going to see when there's something going on with the liver? Of course, you're going to see an increased AST, ALT. We already talked about that. Okay, occasionally you'll see hepatorenal syndrome, which is renal failure. Because if you're not getting enough perfusion to the kidneys, then you're going to have some renal failure. There's really nothing wrong with the kidneys. There's no structural abnormality. But the portal hypertension can cause vasodilation, renal vasoconstriction, and then you get hypoperfusion to the kidneys. The way to treat this is a liver transplant. And it should correct the kidney problem. Again, if it hadn't been too long of this going on. This is just for your review: nursing diagnosis, imbalanced nutrition, impaired skin integrity, excess fluid volume, dysfunctional family processes. So your goals, you want them to rest. Your goal is to slow the progression of cirrhosis, right? So you got to educate them Minimal. You want minimal to no complication. You want them to return to their normal lifestyle. They may need some B vitamins because, again, the liver, if the liver's not processing vitamins, they might need extra. You want them to avoid alcohol, aspirin, acetaminophen, and NSAIDs. What's another medicine that's harmful to the liver? Statins. So they might need to be aware. They might not need to take a statin because, you know, when you put somebody on statins, they do liver enzyme tests, liver function tests. So Tylenol or acetaminophen. Thiazide diuretics can be harmful to the liver. You want to prevent further damage. So you're telling them to stay away from these meds and all to prevent further damage. And treat your cause. They may need a liver transplant. Nutritional therapy is really important as well. They're going to need a protein-controlled diet. They might need protein supplements for protein and calorie malnutrition. Low sodium, we already talked about that. And high calories. They can have carbs, but they need mild to moderate low fat. So what would be a protein controlled? Both are protein controlled. They can have protein. So definitely they could have fish. They could have roast beef. Like a lean cut of roast beef. You want a lean meat for liver because you don't want a lot of extra fat. But the best thing is a high carbohydrate. So vegans would do great on this. And that is all.